Hi, I'm Dave Fernald, the editor of Diagnostic and Interventional Cardiology magazine. I'm here at HIMSS 2017 in Orlando, Florida, and this is one of the largest medical shows in the entire world, and it is all based on healthcare IT. And leveraging healthcare IT is one of the trends that is really taking a lot of departments in the hospital forward with being able to realize cost savings and also to leverage workflow improvements. And I have with me from the Minneapolis Heart Institute, Pam Rush. She's a nurse and the cardiovascular clinical program director, and also Dr. Craig Strauss. He is the medical director with Minneapolis Heart Institute, which is part of Line of Health. And my understanding is that you've been able to use analytics software over the last 4 years to realize $75 million in improvements in the cardiovascular service line.
It's $75 million of improvement to the bottom line, basically, of improved value. So
Okay.
it's capturing revenue, it is reducing cost, it's all of those things. So we have a number of different projects that lead to the $75 million of improvement.
And what were some of your key drivers for savings that you found?
So in clinical variation, it's reducing bleeding complications in the cath lab. Mm-hmm. In supply chain, it's negotiating system-wide supply chain contracting. In coding and documentation,
so you need numbers to actually negotiate with Medtronic and Abbott and
volume, and we did it across our cardiovascular services so that it's not just the cath lab or the EP lab. So the key has been taking data and our data infrastructure with our data warehouse supported by Health Catalyst and looking at clinical variation in the cath lab, in the post-operative CV surgery cases, and then expanding that with supply chain, coding and documentation, particularly for our heart failure patients, all to lead to that 75 million in improvement.
And some of the particulars of that, you had mentioned that there are bleeding complications that you've been able to reduce in the cath lab, and how have you used analytics software to actually have actionable information to do clinical work?
Yeah, so we looked retrospectively at about 9,000 PCI cases and looked at the bleeding risk stratification for those cases and implemented a bleeding avoidance strategy program that calculates their risk in the cath lab at the time of the PCI and allows you to implement bleeding avoidance strategies like closure devices in those that are high risk, preferentially to those that are low risk.
Mm-hmm. And you'd also mentioned that you'd worked a little bit with vendors. So when you have actionable information, what is it that you can use to leverage negotiation with your vendors?
So we've learned a lot about our supply chain, our different variation in clinical and physician utilization of different supplies, and we've tried to standardize that both with our physicians on the practice side and with our suppliers on the vendor side. And that's led to significant savings, partly in each area, in the cath lab, in the EP lab, but also by putting together a structure and collaborating with vendors for an overall cardiovascular supply chain structure and contract.
And Pam, what have you seen with being kind of on the front lines in the cardiovascular service line?
Well, I think that we've had some opportunity with how we do our documentation and coding and being able to capture what's really going on with the patient. We've been able to use some of the data from Health Catalyst, compare ourselves to others in the Twin Cities areas, others like hospitals, that we can look and see how our coding and documentation was capturing revenue and where we had some opportunities for improvement, and then worked with the physicians, had teams of nurses actually out providing coaching, mentoring support to the physicians on how they could document in a way that could better reflect the acuity of the patient.
My understanding is that you've also used analytics to help reduce your length of stay.
Yeah, we've done a number of projects to reduce length of stay and reduce readmissions, particularly in the heart failure area with care coordination. And in the PCI area, again, risk stratifying patients to identify those that are highest risk for readmission and targeting those with care coordination over those that may not need immediate follow-up.
And how have you been able to tie in the IT specifically and get your doctors to use it?
Well, I think a piece of that is really getting our analysts involved with the physicians. So what is the data that they need to make a change? And to have them closely work with them, whether it's with Dr. Strauss or one of our other physicians in the practice, to say what's the data that you need around this clinic or around this condition, or why are they coming back, or what's the complication rate, that they're able to pull the data that makes it very actionable at the time. So having the clinician voice as we pull the data has been extremely helpful.
One of the things I've heard here in the past in sessions is that the data analytics guys in the IT department come up with these great ideas. They go to HIMSS and they sit in sessions like, well, these are all the data points you need to collect. And they go to the doctor and say, look at this great algorithm I wrote for you guys to help reduce readmissions. And the doctors will usually turn around and say, well, what do you know about orthopedics? What do you know about cardiology? So they have a hard time getting buy-in because they don't start off at ground zero with the clinicians. Is this something that you've been able to work with the clinicians starting out?
I think it's a mix. I think that you use some of the data that come from those reports that they've put together, but you have to dig in deeper because that gives you a number of maybe where to start, but it doesn't give you the answer about what needs to happen or what's the change practice that needs to occur, what the problem is.
Well, thank you very much for your time.